Welcome back. We're picking up where we left off very abruptly, ending in the SNOMED video. But I hope you got the flavor of the complexity of that process of categorization, classification, and coding that is involved in SNOMED. What we're going to do now is share the screen and just give you an example of how you can map coding and classifications from the various organizations I showed you earlier who were working on the classification systems, and how they map onto this column, even though it's titled this, is really the SNOMED system. But this is the concept unique identifier over here. So those concepts he talked about that were the idea you have in your head. And these are the classes. ICNP has a code for abdominal pain, but none of the rest of these have that code or something that would map onto that code. Here's one for alcohol dependence. This is the code for ICNP, alcohol dependence. Over here is alcohol dependence under the SNOMED classification system, and this is its code. Let's go down to one where there are more organizations with classification codes. Here's one for anxiety. The unique classifier for anxiety for ICNP is this number. For NANDA, the nursing diagnosis, it is this number. For CCC, it is this number. And for SNOMED, it is this number. So as you can see, some things map across various groups, classification systems. Some are unique to only one classification system, and so forth. So we're in the midst of creating systems, and over time, things that have been generated by these groups may find their way into SNOMED, but at this point in time, these are the ones that had also will show up in SNOMED, which is what most electronic health records use. Now, we're moving from generating data, classifying data, coding data, into using data for quality improvement initiatives. There are usually 6 major dimensions of healthcare quality. It's safety, it's timeliness, it's effectiveness, it's efficiency, it's equity, and whether or not it is patient-centered. So these are characteristics of a high-quality system. So I want to pause right here before we go any farther, because what's going to come after this is largely drawn from the Institute of Health Improvement's Open School course materials. The Open School is free. You can go to their website, register, and then take any number of the courses that they offer there for free. So on September 13th, they migrated to a new system, but it's not, when I'm making this video, that new system, I don't have a URL for it, but I just want to warn you that if you're interested in the IHI Open School, just Google those terms, IHI and Open School, and you'll be directed to its new platform. But I can't say enough good things about it. What you'll find there in the IHI Open School is the plan, do, study, and act concept. It's the way they organize planning for improvement. And you're going to, I hope, see some similarities with what is happening with Agile project management. Hang on just a second. Let me make sure things are happening the way I want them to. Okay. And they are. So let's go on. You're asking yourself 3 questions in this cycle. What are we trying to accomplish? How will we know a change is an improvement? And what change can we make that will result in an improvement? And to answer those questions, you're constantly going around this cycle of planning, doing, studying, and acting. Now, we set our aims at the very beginning, and we ask, we want to know how we're going to know how good our result is, for whom we want it to be an improvement, and by when do we want to see that improvement. We want our aim to be bold, realistic, clear, concise, measurable, and meaningful. That's a lot to ask, isn't it? So how good, for whom, and by when? So which of these two would you think would be a better aim statement? I hope you chose the second one because it met those criteria by for whom, by when, and so forth. We want to decrease the rate of catheter-related infections for patients in the ICU. That's where and when, for whom. From 23 infections per 1,000 catheter days to less than 5 per 1,000 catheter days. That's how we'll know we've reached our improvement goal, is when we move from 23 to 5. Now, there are 3 kinds of measures. I think you saw that in the very first video we saw from British Columbia and Canada, where they talked about there are outcome measures, process measures, and balancing measures. We're going to be deciding on those measures. So, which of these measures below is an outcome measure, which is a process measure, and which is a balancing measure? Take a second and look at that. Make your mind up. The average number of time patients receive the recommended oral care within 24 hours would be a process measure. Patient and staff satisfaction scores, a balancing measure, and the rate of an acquired infection, and that should be an acquired infection for 1,000 catheter days in ICU, that's an outcome measure. Balancing is one of the things I want to talk about here because it's sort of an unusual thing to be looking at. But anytime we add or make a change to achieve a positive outcome, we take the risk of improving what we're changing, but perhaps having unintended consequences, something else going wrong with that change. So it is important not to just improve a process, not to just improve the outcome, but to make sure in doing those things we don't create a problem we hadn't expected. And so the balancing measures are also very, very important. And it could be, and I think this is relevant to missed care, there are things that we do to improve quality, for example, but it may add burden to the nurse's work week or workflow. And in doing so, because there is only a limited amount of time and resources, cause the nurse to have to make a decision to not do some other piece of care so that you can improve care in this one focus area. So I think there's something to be said about looking for what happens with initiatives to improve quality and how they can have unintended consequences, such as missed care. Now, in developing changes, you've got all these things to think about: process analysis tools, how you're going to do that, what are you going to benchmark against. In examples that we gave earlier, we said, well, we're going to benchmark our catheter infection rate against something. Is it a national standard? Is it what is an agreed upon limit. We want what are we going to have as technological solutions and creative thinking and change concepts. So all these things go into developing change. So let's think about these change concepts. We can change things that are under our control. We can eliminate waste, improve workflow, optimize our inventory, enhance the producer-customer relations, change the work environment, manage time differently, manage variation in quality, design systems to prevent errors, and focus on the design of products and services. And all of these things rely on data and information that we can use in that plan, do cycle. So let's just stop right here and take another example. What changes could improve oral care in ICU? What changes in workflow might improve oral care? How could we optimize inventory to improve oral care, or change the work environment, or manage variation, or design systems to prevent errors? Let's pause a minute and give that some thought. To improve workflow, we might ensure that all the mouth cleaning supplies are kept in ready-to-go state. So we have it ready so that workflow does not have to include hunting our material to give mouth care. Optimizing inventory, we have to have that material ordered in a timely fashion so that we don't run out, so that we can assure that it's kept in a ready-to-go state. We can change the work environment by training hospital staff. We can manage variation by giving updates on oral policy to be consistent with CDC guidelines. And then to design systems to prevent error, we can post the oral care protocol in visible places. So these are all things we can plan and do and act upon. But we have to test those things to see if they are really going to produce an improvement, because we don't just jump on our bike and ride off into the sunset having done everything right with just one try. Remember that this is a cycle, just like our agile project management. We're going to put some things into effect and see if we've made a change that resulted in improvement. So the planning is coming up with our questions: who and when and how will we know? The do, we observe before we do something, and then we test the outcome of doing something. We document our results, and that's where informatics comes in. We study it. We sometimes plot things on what they call run charts, where we might have the rate of oral care, the percent of patients receiving the recommended protocol for oral care each day, and then analyze those data before and after we put those other changes into effect, that managing the inventory and the workflow. And then we refine the change. We see what resulted from our planning and doing and studying, and then we modify and act again, because we may not succeed at the first attempt. Again, as in agile project management, we take little baby steps, we put them into effect, see what they did, and then tweak at the next stage. Again and again and again and again. And eventually we'll go from here to here in reaching our goal. So we want to think small, bite-sized changes we can make, think ahead, think where we're starting and where we want to end up, and don't wait to begin. Be bold, as you remember, and creative in that first slide about change. So here's a case study. Let's go over it together. There was a physician practice that wanted to achieve better blood pressure control in all patients, and they wanted to have people with blood pressures 140/90 or below. That was their target. The target measure was the percent of patients 18 to 75 with ischemic vascular disease, diabetes, or hypertension with a blood pressure consistently below 140/90 when taken at the clinic. Now here's a very good aim or target measure. For hypertension patients, they wanted to reduce the blood pressure readings across the entire patient population so that blood pressure readings in the clinic were consistently lower. For diabetes patients, they wanted to increase the number of controlled blood pressure readings to 85%. Their baseline had been only 73%. And for ischemic vascular disease and hypertension patients, increase patients in the acceptable range to 90%. Their baseline had been only 68%. So they had very measurable and realistic and complete measure and goals. One of the key things that helped their practice achieve their goal was that they decided to move away from thinking that blood pressure control was the doctor's problem, but to make it an entirely shared team problem and team effort to support patient health, whether it was the person making appointments or greeting people when they first came in and took their information, all the way down to the care team who were responsible for giving courses on better diet control and lifestyle changes. So everybody in the office basically was working for the same goal. They had a quality leadership team that were really responsible and committed, and they wanted to go beyond just good care to the very best care possible. So they had a lofty, bold, and creative goal. Again, I will emphasize that they mobilized the entire team, and they had monthly meetings about this initiative to review their data and to see their intervention results. They used the plan, do, study, act cycles. They had a patient or a care coordinator who was a specialist in working with patients directly for education about their condition and to refer them when they needed outside providers and then to help evaluate their progress. Everyone agreed to take responsibility for the blood pressure improvement. And again, I will say it wasn't just the physician's problem, it was everybody was involved in this endeavor. And not only every provider, but every visit was considered a hypertension visit. Even if a patient came in for a complaint not related to hypertension or diabetes or vascular disease, they still were tested for their blood pressure, and new cases were found that might have been overlooked in the past. They had a registry, which was exported data from their electronic health record that was extracted from by a computer programmer who was support for their electronic health record functioning. And every 3 months, they had a report pulled by the computer programmer that gave them a good bit of information about the patients they were seeing. And then from that, they could create lists of those who needed more close supervision. They moved from having a one-to-one patient focus to a population focus. That registry where they took all their patients and looked at the blood pressure readings for everybody that came in enabled them to take the broad view and not be focused only on people who had already been identified as having a problem that might be related to hypertension. And I'll show you what the data look like, because you'll see that with this registry and this data that were pulled from the electronic health record, they were looking at blood pressure, lab values, tobacco and aspirin use, and A1C for the diabetes patients. They also stratified people by risk factors and by those who were most likely to make a change because they had had success in controlling, say, their A1C levels or stopping smoking. I'll say more about that in a minute. But here's what the registry reports would look like. This has been blocked out as the patient's name, but they had the blood pressure reading, and in this particular view, we only have this patient here who would have been warranted some attention based on their blood pressure reading. And here, the diastolic was high, but the systolic was within range. But still, this patient was identified as perhaps needing to have a little bit closer look. And lo and behold, they had an A1C that was out of range. And they were sent in for the lab to update this. You can see, so blood pressure was a way that they targeted some patients. A1C rates or another way. When they had had their last A1C drawn, here's someone that was late on getting an LDL lab work done. And these are the people who used tobacco. And so that warranted special care and closer attention. So with these data, they could pick up people they might have missed otherwise. Interestingly, they didn't pick up this particular patient. Very interesting. All right, so you can see that when you get, you can harvest information from your electronic health record that is very useful in identifying where you need to put your emphasis and who you might have missed otherwise. So they reached out to patients who had been identified as at risk and did some pre-visit planning to make sure that their charts were flagged so that as they came in, it was obvious to the provider that they needed special attention. And here they say the care coordinator and providers focus mostly on patients closer to optimal control. So they didn't, they took some of the areas where they could be the most successful because people had shown that they were controlling some of their other indicators in other areas. It's an interesting concept. Instead of starting with the most out of control patient across the board, they picked those that they could probably put their resources there and get better control. That is one of those ethical, moral values, judgments that a nurse leader or informaticist could help a practice make. Within the visit, everybody, as I said before, no matter who they were or what they came in for, had their blood pressure recorded and documented, and where necessary, changes in lifestyle and medication were discussed. Thought this was interesting when they had the initial screening of their blood pressure. If it was out of range, out of the acceptable range, they had a magnet that they put on the door so that it was red and it said recheck blood pressure. And so 15 minutes later, they would go in and take a second blood pressure reading to make sure it wasn't just that white coat hypertension or that they were not settled comfortably and calmly for the first reading. So I thought that was clever. If after the second reading they were still elevated, they might be asked to return in 1 to 2 weeks for another reading. And if at that time the blood pressure was still elevated, the patient was referred to a care coordinator for special intervention. Training, and more training. Staff were trained extensively several times during the process about taking the blood pressure and about the workflow that would be expected in this new initiative of catching hypertension and managing it more efficiently. Order set, I mean, they came up with policies about when people should return to the clinic and what kinds of required lab tests and follow-up visits and interventions would be necessary for which types of patients. Of course, there was a lot of patient education going on. They had the luxury of a patient care coordinator position in that practice. They were very careful to keep special notes in the EHR about after-visit summaries so that patients will be able to read these after-visit summaries themselves, and the next provider could also look at those and tell what patient goals had already been discussed with that patient. There was a patient portal that patients could go in and make appointments for their next visit, but also find out about their lab results and so forth. So every step of the way, there were things going on to improve the outcomes for these patients. They had great success among the patients with diabetes. They went from 73% controlled blood pressure to 97%. And for those with ischemic vascular disease, they went from 68% to 97%, managing their blood pressure within the tolerance of those limits. So, and they overall had reached their goal of 90% for all of those. So they did a very good job of getting that. Their next step was creating a specialized database for diabetes and ischemic vascular disease patients. And how to find out the kind of clinical data that needed more attention during the next patient visit. So they were still working on their data collection and their identification of patients using the electronic record. They had to, of course, change their workflow because they changed their focus. So they took a great deal of aggressive, what they call flow charting, to see who's going to do what, when, making sure that something didn't get left out and that somebody thought that wasn't their job. But so, as we said very early on, I think day one, if you change something in an initiative to improve quality, you better know what all the steps in the patient care workflow are, or something can be left off. So key lessons: they learned to foster communication, to engage staff in not just to inform them about what's going on, but to actually get them involved in the planning. They really emphasized to use their staff at the highest possible level allowable under their license and expertise. There are sometimes people in the environment that have great expertise or an advanced certification or license, but they're not able to use that in the current situation because maybe it's not appreciated. But they found that using those people to the highest level that is warranted creates success. The shift to a population management mindset was very helpful to them. It identified more patients than they would have normally identified as needing management. That care coordinator position and program was very beneficial. And they worked with the vendor, the computer programming experts, on the registry development to pull reports and let them figure out ways to be sure that the patients were coming back in when it was time to come back in. And they used both low-tech and high-tech strategies for gathering information about the success of their program. That communication that was so important might have been just a casual conversation or a team meeting where the people were asked to say what they thought was working and what wasn't working. Now, I think I'm going to stop after this slide because this is really the crux of what we've been talking about. The need to collect the right data is great, and we've seen how difficult that can be. But to also use those data well, as in that case study where you put the data to work for you to identify who needs your care, to trace your steps as you go through delivering care and getting reports from your electronic health record that will tell you where your needs are greatest. I think that will sum it up for today. We'll see you for class 3, and you'll break and have some opportunity now for some tutorials following this presentation. So thanks again for your attention.